So today's class is on rheumatology and it will be taken by Dr. Varun Pushkarna. So, sir, you can take over the class.
Yeah, thank you. So basically, rheumatology is a very important topic, and most of the times people don't pay attention to it, and it is simply thought of as either rheumatoid arthritis or maybe SLE, and then it is left to that only. But it is a vast topic, and you will get around 15 questions in the exam from rheumatology. Out of 200, 15 questions is a big number. And then there are certain drugs, pharmacology, which is also associated with rheumatology. Hence, they these questions can also come under the same banner but differently. Third, immunology also is considered as a outshoot of rheumatology. So the basic sciences, clinical sciences, you will get few questions aligned to rheumatology from these topics. So I have a question for all the contestants, all the students here who are appearing for MRCP. Do you want it to be a theory-based intensive class, or do you want it as a class which gives you a fair amount of idea with a lot of MCQs? Because I can switch over to both modes. Once we begin in one, we will continue in that only. I have no idea of your preparation level, so you can freely tell me in the box as to how do you want the class to be, and we will take it like that. Okay. So you want MCQs? Everybody is okay with that? Great.
Yes, sir.
Okay. So in any case, if you, yeah, okay, great. Somebody has very nicely mentioned if it is feasible to start with the theory topic and then discuss MCQs. Okay, fine, we can do that as well. So let us begin with rheumatology, and I always believe that rheumatology can be a boring topic, but we can make it interesting by sticking to the more interesting issues initially, and then we cover everything else. So the big king of rheumatology, rheumatoid arthritis, it is a chronic autoimmune disorder. So what is autoimmune disorder? Where the immunity has gone bad. It is basically our own immunity which is attacking the organs of the body by a phenomena either known as antigenic mimicry, that is some other organisms mimicking the same antigens that we have. So in an attempt to kill those organisms, body starts killing itself. One is mimicry, the other is hidden antigen concept. So some antigens, like for example the DNA is inside the cell, inside the nucleus, and there it is DNA. Imagine this DNA comes out and is exposed to the circulating blood, then anti-DS DNA antibodies will be formed, which are hallmark of autoimmune disorders. So this is how the autoimmunity triggers. Now, what is wrong in rheumatoid arthritis? It is also autoimmune disorder, but it primarily affects the joints. Now, when I say primarily affects the joints, that means it's not the joints only that are involved. Other organs may also be involved, but mostly it is the joints that are involved, resulting in an inflammatory synovitis. Now, there is a difference between arthralgia and arthritis. So when it is only pain, it is arthralgia. When there is swelling, pain, stiffness, it is arthritis. Or in better still terms, it is called synovitis. Why? This is the bone, this is the bone. Here is the joint synovial capsule. This gets inflamed. Why? Because there is a debris inside which is triggering the inflammation, and this inflammation is actually eating out the cartilage that is there on the tip of the bone. Now, this cartilage damage leads to deformity of the joints eventually. Hence, rheumatoid arthritis becomes a very, very important diagnosis and a matter of debate whenever it comes to rheumatology. It is usually more common in women, young 30 to 50 years productive age group of body of life. And it is important from MRCP that they have been asking this question many times now, that what is a preventable risk factor? All a question will come that a 30-year-old female has come with polyarthritis, complaining of pains in multiple joints of the hands and feet since 3 months, and they will tell you a silence, and they will tell you a story about it, and then they will ask what is the most pertinent advice in lifestyle change that you will give to this patient. The answer is quit smoking, as simple as that. So basic questions can come from rheumatology, nothing to do with the pathophysiology, nothing to do with the drugs, nothing to do with the presentation, just the preventive aspect of it. What you can do is quit smoking. Now, going on to the pathogenesis, so both T cells and B cells are at fault. There is a proper response from both of these lineages, immune lineages, leading to damage of the synovial cartilage. There is a very well known concept of interferon gamma attacking the cells, activating the macrophages and attacking the synovial cells and damaging it to the core. Interleukin 17, synovial plasma cells producing antibodies against self antigens like citrullinated peptides. Now, this question has come in the exam as basic as that. That in the pathophysiology, which of the following are true and false? So, it is not the WBCs circulating which are making these antibodies. It is the synovial plasma cells which are in the synovial fluid. These synovial plasma cells are the ones that make the most famous anti-CCP antibodies, that is citrullinated peptides. The HLA association is there. HLA association means some people are genetically predisposed to develop rheumatoid arthritis. How do we define those patients? These are those patients who have congenitally inherited HLA-DR4 gene in their body system. Associated conditions or syndromes are Felty's syndrome, where rheumatoid arthritis presents with TLC of around 2000. There is neutropenia with around, so this will be like 20% polymorphs and 60 or 80% lymphocytes. So this can be the picture, and rheumatoid arthritis can present with neutropenia along with splenomegaly. So this is Felty's disease or Felty's syndrome. Then there is Kaplan syndrome, which is found in poll workers. So whenever there is a history of coal work associated with and rheumatoid arthritis, and they give you that there are multiple nodules in the lungs, this is Kaplan's syndrome. Factors of poor prognosis are when males have it, when it is slow to originate, and when it originates late in the life. There are, and then anti-CCP has higher value of anti-CCP.
Sir, can you repeat that poor prognosis factors?
Yes. Male gender, slow onset of disease, late onset of disease, presence of anti-CCP antibodies, and when number of joints involved is more than 5. So these 5 features, they indicate the poor prognosis. When it presents in males, when it presents late onset, when it late on, and when it is slow to progress. Slower the rheumatoid arthritis, worse it is. Why? Because one is that the patient will come to you late. Second, the disease would have progressed by then. So if it progresses fast enough, the patient will come to you early. You will treat the patient early. So male gender, late age of onset, slow to progress, where anti-CCP levels are higher than rheumatoid factor, when the number of joints involved are more than 5. These are the poor prognosis. Clinical features, of course, all of these patients are fatigued. This is the first and foremost sign of 99% of autoimmune disorders. Then morning stiffness that lasts more than 1 hour. 30 minutes is also fine, but then it has to be a perfect, that is association, that is it has to be present daily. Pain, stiffness, swelling. This defines synovitis. That is arthritis. Which joints? So it is the metacarpophalangeal joints and proximal interphalangeal joints. Remember, if it is affecting the distal joints, it is anything else but rheumatoid arthritis. So whenever in the question paper you see DIP is involved, it is not rheumatoid arthritis. Not that it cannot exist in the open market, like the patients that come, they can have. But why? Because rheumatoid arthritis and osteoarthritis both can present in the same patient. But that is a far-fetched idea for an exam. For as a dictum, distal interphalangeal joints cannot be involved in rheumatoid arthritis. It is a dictum. It is a medical dictum. If it is not that, if the distal joints are involved, it is either osteoarthritis or psoriatic arthritis or ankylosing spondylitis with peripheral involvement, but it is not rheumatoid arthritis. Mark it, underline it. If the distal interphalangeal joints are involved, the patient has rheumatoid arthritis. And of course, metatarsophalangeal joints involvement. Okay. Then all these patients, they have chronic anemia of chronic disease, they have weight loss, decreased grip strength. So there is a test known as hand squeeze test. Anybody knows about this test? So basically what happens, you just shake the hand with the patient and the handshake should be firm enough. So that will trigger the pain so much that the patient will withdraw their hands. This is classical test positive for rheumatoid arthritis. Of course, they will also have a weak grip strength at the same time. Subcutaneous nodules. Remember, subcutaneous nodules are having very less differential diagnosis. One is rheumatoid arthritis. Anybody else can tell me something else? Subcutaneous nodules in the medical literature where MCQs are involved, where do you all see other example of subcutaneous nodules?
Infective endocarditis.
Where it is asked in the exams?
Erythema nodosum.
Say again.
Fever.
Infective endocarditis.
Infective endocarditis.
Infective endocarditis or
Rheumatic fever.
or rheumatoid arthritis or rheumatic fever.
Yeah, rheumatic fever.
Rheumatic fever.
Yeah. So rheumatic fever, subcutaneous nodules are prominent feature there. Splenomegaly, ulnar deviation of the fingers, swan neck deformity. These are some things that you have already been studying, these deformities throughout your MBBS and cramming them up for NEET PG. But these are not usually asked in the MRCP exam. More important things like the involvement of DIP, hand squeeze test, poor prognosis, true and false, they will be asked. On imaging, see, X-ray, not many people are ordering for rheumatoid arthritis. It is a very important test. Why? Because you can see erosive nature of this arthritis. Although it is not as erosive as psoriatic arthritis is, psoriatic arthritis is so erosive that it is known as arthritis mutilans. It literally destroys the joints. But rheumatoid arthritis also has a significant element of erosive arthritis. Particularly bony erosions are there. They are hallmarks. There is diffuse osteopenia. You can make out that the bone is literally weak. It is not as radio opaque as it should be. Joint space narrowing will be there in the carpal, metacarpal, and phalangeal, interphalangeal joints. Ulnar deviation you can see on the X-rays. And in the laboratory tests, it is important that RA factor should be done, or rheumatoid factor should be done. This question is very important for MRCP. What is a rheumatoid factor? It basically is an IgM antibody. So, if something is an IgM antibody, can it cross placenta? Can it cross placenta?
No, sir.
No, sir.
No. Very good. So IgM is a big antibody. It cannot cross placenta. And the irony of the matter is that this is an antibody against antibody only. So it is IgM antibody against IgG.
FC portion.
What IgG? It's FC portion. Yes. So it is an antibody which is targeted against a subset of immunoglobulin G. Okay. So this is a missile against a missile. It is not against a particular organ. That is why the inflammation is so profound in case of rheumatoid arthritis, because already there is an IgG formed, and this IgM is against that antibody. And normally what happens in, like we read in vaccinations, that initially it is IgM, which then converts to seroconversion happens, and it eventually converts to IgG, isn't it? But here, rheumatoid arthritis is one unique situation where throughout life, the IgM does not convert to IgG. It remains IgM. Is that clear? Normally, like in chicken pox, we see, okay, IgM is initially positive, then it becomes IgG. In HIV, HCV, hepatitis B, it is IgM to begin with and IgG later on. Because IgM, we know, it goes up and then comes down. IgG becomes like this and then remains positive all the life. Here, IgM remains positive all the life because of multifactorial, multi-plasma cell triggering. Is that okay? Understood? Okay. So this was rheumatoid factor. Then comes anti-CCP antibody, much specific, much specific. Let us say somebody has symptoms, but rheumatoid factor is negative. But symptoms are very typical. The next investigation is anti-CCP. Why? If anti-CCP is negative, the chances are this patient may have SLE, may have chikungunya, may have anything else, but not rheumatoid arthritis. But if it is positive, then the patient certainly has rheumatoid arthritis. Is that clear? So rheumatoid factor is important, but anti-CCP is much more specific. It may not be as sensitive. So it's not important. It's not necessary that it become positive. But if it is positive, it is not anything. Sorry, I had to take that call. So anti-CCP is much more specific than rheumatoid factor. For rheumatoid arthritis, rheumatoid factor can be found in any diseases, even in viral fever, sometimes it comes positive. The anti-CCP can predict eventual development into rheumatoid arthritis when found in undifferentiated arthritis. So when a disease is less than 3 months, you cannot label it as rheumatoid arthritis, so you call it undifferentiated arthritis. So if anti-CCP is positive before 3 months, I mean the patient comes to you within 3 months of onset of symptoms, you cannot call it rheumatoid arthritis. By EULA definition, somebody has to have more than 3 months of symptoms. But let us say they have come to you within 3 months and you tested them, anti-CCP is positive. Right now, the patient is undifferentiated arthritis. Why? Because the duration is less than 3 months. But if anti-CCP is positive, there are chances, high probability that this patient will develop full-blown rheumatoid arthritis. Why? Because this anti-CCP, as I told you, this is an antibody which is produced by the synovial plasma cells. So if it is being released right there and then, it is high probability that the joint will be eaten up. Hence, this is an important marker of erosive disease. It may be detected in healthy individuals much earlier than the diagnosis is made. Sometimes patients are totally asymptomatic, but because of their fatigue, because of their tiredness, sometimes people tend to get their anti-CCP levels done. And when they are positive, they can predict even 10 years in advance that this patient can go on to develop rheumatoid arthritis clinically. It is better than rheumatoid factor for diagnosis. Why? Because anti-CCP will not be positive in SLE. Anti-CCP will not be positive in Sjogren syndrome. Anti-CCP will not certainly be present in scleroderma, but rheumatoid factor can be positive there. Okay. Important is that the levels of anti-CCP will not fluctuate with disease activity. So even if you give steroids, put the patient into remission, the anti-CCP levels will not rise or fall. However, rheumatoid factors can rise or fall with treatment. Increased ESR and CRP is the universal finding in all the inflammatory disorders, so they will be there. Main differential features differential diagnosis will be SLE, psoriatic arthritis, osteoarthritis, viral arthritis of parvo B19, or chikungunya. Treatment, very important, smoking cessation. Initially, the treatment is non-steroidal drugs and steroids, but eventually these patients will be required disease-modifying anti-rheumatoid drugs as soon as the rheumatoid arthritis is diagnosed. DMARDs, for example, methotrexate is the king of DMARDs. Hence, many questions in MRCP, rheumatology, pharmacology will be addressed to methotrexate. DMARD of choice acts as a folic acid antagonist. Side effects are GI. Not many people tolerate it. Oral ulcers can occur. Stomatitis happens. Macrocytic anemia. Why? Because the same pathway is folic acid pathway, which is inhibited, and hepatotoxicity. Very important that you continue to repeat SGOT-PT. By EULAR guidelines, it is 15 days, every 15 days for first 3 months, and then every 6 months. You need to repeat the transaminases levels, SGOT, SGPT, every 15 days initially, and then higher on. So, another drug which is very important is leflunomide. Again, very, 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 very hepatotoxic. So, monitoring of liver enzymes is very important. Sulfasalazine, time-tested anti-inflammatory painkiller, also can be classified under non-steroidals and DMARDs, both. Very good drug, lesser used because lesser tolerated. Hydroxychloroquine, usually the second drug in line after methotrexate. So this is the usual combination that most of the patients they take. Eventually, these patients may require azathioprine. I will give you a situation just in a moment. How DMARDs help? They improve the symptoms. Symptomatic relief is there. The number of joints involved decrease. Definitely decrease. This is an MRCP true and false question. They reduce the inflammatory markers like ESR and CRP. They slow down the radiological injury. They slow down the disease progress, and they also correct the anemia of chronic disease. Okay. Now, I have a question for you all. A lady wants to conceive. She has rheumatoid arthritis and she has been on methotrexate. Because methotrexate is a it can be used as an infertility agent. It can make the person infertile because of folic acid pathway inhibition. And the problem is the patient is symptomatic. So you have stopped methotrexate. What is the drug that can be used in rheumatoid arthritis patient during pregnancy?
Sulfasalazine and hydroxychloroquine.
Azathioprine.
Wonderful. Azathioprine is the answer. So azathioprine has no labeled contraindication in pregnancy. Hydroxychloroquine has, sulfasalazine has, leflunomide has, methotrexate has. So there should not be any confusion in your mind that if a pregnant patient comes to you in the exam as a patient of rheumatoid arthritis, then the answer will be azathioprine. Okay? Other drugs are biological drugs, newer drugs. They are targeted against the whole process of pathophysiology. So it is like you can use rituximab, which is anti-CD20. So it stops the immunoglobulin synthesis by the plasma B cells. Then tumor necrosis factor alpha inhibitors like etanercept. Adalimumab is an excellent drug. Excellent drug. And what is the dose in which adalimumab is used? It is now coming again very frequently, this question. It is 40 mcg subcutaneous every 2 weeks. Now people find it very difficult to remember and they will tend to forget. But this is just one drug where you have to remember the dosages. 40 milligram subcutaneous every 2 weeks you have to give adalimumab. And you have to test these patients for all the communicable diseases prior to be started, like tuberculosis. You have to rule out that they do not have latent TB. You get your HBS antigen tests done, HCV, HIV, all these tests. Once you're done, you can start the patient on adalimumab. Rituximab is asked again and again in the exam. CD20, anti-CD20, it is suppresses the B cells and has other uses also. Methotrexate, I have told you that this is a hot favorite topic of MRCP examiners. So there are certain important things. You cannot combine methotrexate and cotrimoxazole or trimethoprim. This question has come a number of times. It will come again. For example, they will tell you that a patient was a rheumatoid arthritis patient, also has HIV. So as a preventive regime, the patient was started on this cotrimoxazole or trimethoprim. And the patient has come to you with leukopenia, worsening leukopenia. What should not have been done? The answer is the patient should not have been started on cotrimoxazole if he was already on methotrexate. Why? Anybody?
Causes pancytopenia.
Yes,
Both of-
Yeah, that is what I am saying. But I need to know why.
So both are anti-folate drugs.
Wonderful. So both of them are anti-folate. You cannot combine two anti-folate drugs. It will be a disaster. The bone marrow will be gone, literally. So what is the therapy for the rescue?
Sir, IV folinic acid. IV folinic acid 75 milligram.
Wonderful. So intravenous folinic acid 75 milligram is the treatment of choice. Okay. If the patient is on methotrexate, live vaccines should be avoided. Which are the live vaccines?
BCG. Polio. Oral polio. Yellow fever.
COVID.
Yellow
COVID
fever.
vaccine also, there is live attenuated virus vaccine is also available. And then, so you should be, on terms with these vaccines. Which of the following are the live vaccines which cannot be given? Tetanus can be safely given. Hepatitis B antigen, chickenpox, subunit vaccines can all be given. Non-steroidal anti-inflammatory drugs can reduce the excretion of methotrexate. They are not contraindicated, but the combination should be monitored carefully. Alcohol is an absolute contraindication. Okay? Methotrexate is contraindicated in patients who already have bone marrow depression. It is teratogenic. Effective contraception is required in treated men and women of childbearing age for at least 3 months after discontinuing the drug. They cannot conceive for 3 months. This exam question is very normal. That a couple has come to you for counseling. They want to conceive. You have stopped the methotrexate. Until what time they should continue with contraception? 3 months. Very important. Methotrexate can decrease fertility. Probenecid, which is an antiurate, can severely inhibit renal excretion of methotrexate and is contraindicated. It will lead to bone marrow depression and hepatotoxicity. Phenytoin and theophylline also should be avoided as they may increase methotrexate levels. Time to response is very slow. So you should guide the patient that the treatment will begin, but the patient will start feeling relief after 6th dose. Why? Because it's once weekly. It has to be given once weekly. Monitoring full blood count and LFT monthly for 3 months. Once the patient is stable with no alteration, then every 2 to 3 months with the renal profile every 6 months. This is important. So these are the, okay, then there is a DAS 28 scoring. Many times students ask me, what is the algorithm of going from non-steroidals, steroids, DMARDs to biologicals? For example, a patient has fever, you start them on oral paracetamol. The fever doesn't go away, you give them something else like ibuprofen. Still doesn't go, you give nimesulide. Still doesn't go, you give them injectable paracetamol. So there has to be a hierarchy. the hierarchy in rheumatoid arthritis is followed with the help of DAS28 score. What is it? It is basically a composite score known as disease activity assessment score. So we assess the activity of the disease. It includes the number of swollen joints. So the numbers are given, like the hand joints are given more marks. The lower limb joints are given very less marks. The large joints are given very less marks. The small joints are given higher marks. So this is how it is. You can download it from the internet. You can read about it. It might be there in the books as well. But then you need to know that it includes the number of swollen joints, number of tender joints, number and the inflammatory markers, CRP and ESR, both of them, and a global assessment. Anything, if you are treating the patient on methotrexate plus HCQS, but the DAS28 score is more than 5.1, you need to upgrade the treatment. If the methotrexate is given at 2.5 milligram, go up to 7.5, go up to 15, go up to 25. This is the pathway. Okay. So DAS28 scoring is required and should be calculated in all the rheumatology clinics where the patient is being managed for rheumatoid arthritis. These are the EULAR criteria. Joint involvement, one large joint has no reputation, mark only 0. 2 to 10 large joints, we still give some respect to it, 1 score. 1 to 3 small joints even, the score is 3. Imagine if the more than 10 joints are involved with at least 1 small joint, the score is 4. So number of joints and the type of joint, both of them are very important. Smaller the joint, small packet, big damage. So this is what it is. Serology, negative rheumatoid factor and anti-CCP is 0, low positive and anti-CCP. Okay, somebody asked me what is low positive. When the rheumatoid factor and anti-CCP is less than 2 times, it is called low positivity. When it is more than 2 times, it is called high positivity. So if it is low positive, marks are 2. If it is high positive, marks are 3. Acute phase reactants, normal CRP and ESR is 0 and is there. But if OR is there, abnormal, either of them is positive, score is 1. Duration of symptoms, less than 6 weeks, 0. More than 6 weeks, 1. Anything more than 6, rheumatoid arthritis. Is that clear? Yes?
Yes, sir.
Okay. Let us find out. Yeah. All right. So we will have few questions. So we can revise the topic for you. So rheumatoid arthritis is a chronic inflammatory systemic disorder, inflammatory in nature, primarily affecting the joints. Autoimmune process, involvement of genetics. Which genetics is important? Okay, come on. Now you know.
It's a DR4.
Okay. Symptoms are polyarthralgia, joint pain and stiffness, particularly in morning, lasting for more than
1 hour.
1 hour. Very important. 30 minutes is not the definition. Definition is 1 hour. Usually small joints. Extra articular manifestations are rheumatoid nodules in the skin, in the lung, vasculitis, and ocular symptoms. I did not tell in the other class, in the previous one. So ocular symptoms are scleritis and episcleritis. Very important. These are the deviations. Okay. All right. Now let's do the practice questions. A 55-year-old woman presents with pain and swelling of her hands and feet. She reports morning stiffness lasting over an hour. She is 55. She has pain and swelling in her hands, also in her feet. There is morning stiffness lasting more than 1 hour. Her rheumatoid factor and ACPA both are positive. ACPA is anti-CP. Okay. What is the first line treatment for this condition? Answer is Answer is methotrexate. The question is very clear. The patient has all the symptoms, although the duration of symptoms is not mentioned, but rheumatoid factor is positive, anti-CP antibodies are positive. What is the first line of treatment? DMARDs, and in the DMARDs, first line is methotrexate. So the answer is methotrexate.
Sir, one thing from the when the diagnosis is made, first to start with DMARD or not NSAIDs and DMARD?
The first line treatment has to be methotrexate once the diagnosis is made. Let's go to the previous slide. You must remember that the first diagnosis, once the diagnosis is made, look at here. I specifically mentioned here in parenthesis, to be started as soon as rheumatoid arthritis is diagnosed, because NSAID is symptomatic relief. DMARDs to be started as soon as RA is diagnosed. So if your patient has rheumatoid arthritis, you have made a diagnosis, don't waste time, start the patient. There is so much of data now, so many randomized trials. Earlier you start methotrexate, better it is. Sometimes reversal of rheumatoid arthritis happens if the patient has been started on methotrexate right in the beginning. Is that clear?
Okay, sir.
Good. All right. A 40-year-old man with history of rheumatoid arthritis presents with shortness of breath and cough. Chest X-ray shows interstitial lung disease. Which medication is most likely contributing to this complication? Metho, etanercept, HCQS or prednisone? The answer is methotrexate. Why? Because methotrexate causes fibrosis. Fibrosis in two organs, lungs and liver. So the patient can have interstitial lung disease and cirrhosis of liver. Is that clear? Methotrexate causes fibrosis of lungs and liver, both. Okay. A 60-year-old female comes to you with rheumatoid arthritis, has been on long-term steroid therapy. She presents with sudden onset severe hip pain. X-ray shows a crescent sign. What is the most likely diagnosis? Osteoporosis, avascular necrosis, septic arthritis, or gout? The answer is avascular necrosis. Long-term steroid causes it. The crescent sign on X-ray is pathognomic, hallmark. Next question. A patient with rheumatoid arthritis develops fatigue and a malar rash. She is a known case of rheumatoid arthritis. Now she has fever, fatigue, and a malar rash. ANA comes positive. Not only that, now dsDNA is also positive. What is the most likely diagnosis, which was earlier not correctly made? The answer is
SLE.
SLE, because anti-dsDNA and anti-Smith antigen, they are very specific for SLE. So either this patient has a overlap syndrome or this patient has a SLE. Because in rheumatoid arthritis, dsDNA will not be positive. So if the dsDNA is positive, it is very specific for and sensitive for SLE. Okay. Okay. A 50-year-old lady with rheumatoid arthritis reports increasing joint pain despite taking methotrexate.
Sir, I have a question.
The DAS 28 score will be more than 5.1. That can also be mentioned in the exam. She is started on infliximab. What is the primary mechanism of infliximab? It is TNF inhibitor. Okay. So these are the types of questions that you will have in rheumatoid arthritis. Is that okay? Any doubt in the mind regarding this rheumatoid arthritis?
Sir, I have a question.
Yes, go ahead. Please ask.
Sir, in infliximab-induced drug-induced lupus, I have read that there is a possibility of positivity of anti-DS antibody. It is true.
Say again, in drug-induced?
In case of infliximab-induced drug-induced lupus, in that
Yeah.
case, anti-DS antibody may be positive. It is true or false?
See, any drug can cause this SLE. Any drug. But you have to understand that once it is drug induced, it is the antihistone antibodies which become
Histone
positive.
antibodies are to be positive, sir. Not
Okay.
dsDNA. Sir.
So if the dsDNA is coming positive,
So
then we say that it is an SLE
SLE.
which got triggered by. So in infliximab, the chances are sometimes even ANA comes positive. Sometimes, because infliximab is acting as a TNF inhibitor, no. So what is happening is that this tissue necrosis factor is actually acting on these cells, any cell, leading to damage and opening up of the nuclear membrane, leading to the loss of dsDNA in the circulation. So when we are using TNF factor inhibitor, many times the SLE can be triggered. That happens with adalimumab also. So this problem is there, that once the SLE is triggered, we have to differentiate. Why we have to differentiate? Because in SLE, the diagnosis is lifelong. Whereas in drug-induced SLE, the diagnosis is short-lived. Why? Because these patients get better. This is what is important, that in TNF factor alpha inhibitors, many times SLE with antihistones will be negative, but anti-dsDNA will be positive. Still, why it is important for us to know? Because the treatment will be lasting only for a short time. The patient will recover. Are you getting my point?
Yes, sir.
It can definitely cause, even adalimumab can cause.
Sir, my question is, what he asked is, will a patient with a drug-induced lupus will have dsDNA? Can that be true or false?
Yeah. In case of anti-TNF alpha inhibitors, it is true, but it is not a universal finding.
Okay. It
can be positive.
It can be positive.
Yes, it can be positive.
Okay.
But the point that I am making here is that antihistone antibody will be negative.
In drug-induced?
No. In infliximab. This is what I am saying.
Oh.
In infliximab, classically the antihistone antibody should be positive.
Yes, sir. Drug-induced.
But in TNF effector alpha inhibitors, it is the other way around. The antihistone antibodies are negative, but anti-dsDNA is positive. Why it is important for us? That despite the anti-dsDNA being positive, it is not a lifelong SLE diagnosis that we are making. It is a drug-induced diagnosis only. Why it is important? Because then the treatment will last only until the infliximab effect remains. After that, it wears off, SLE goes away. That is why infliximab and adalimumab, most common rash is a butterfly rash. Are you getting my point?
Yes, sir. I'm clear.
And kidney will not be involved.
Okay. So you mean to say that SLE, the basic pathology is also in TNF, like rheumatoid?
Basic pathology is?
The involvement of TNF, tissue necrosis factor.
Yeah. TNF factor alpha is one of the very important cytokines which initiates the whole disease process. Even fever comes with whenever viral or bacterial. Yeah. So whenever the TNF alpha is released, it is one of the important reasons why the nuclear antigens are released into the circulation. That is why, yeah. The importance of this statement that the doctor asked is that in infliximab and in adalimumab, you have to understand that antihistones will be negative if the SLE is caused by infliximab. But anti-dsDNA will be positive. Still, it will be known as drug-induced lupus. All right? Okay. Now SLE. We were talking about SLE, and now SLE is there. So what is SLE? SLE is the umbrella of autoimmune disorders. This is SLE. This is rheumatoid arthritis. This is Sjögren's syndrome. This is scleroderma. This is dermatomyositis. This is polymyositis. This is vasculitis. This is nephritic syndrome. SLE can present like anyone. So SLE is a systemic autoimmune disease characterized by acute flares. So sometimes it's at the peak, sometimes it's at the bottom. Sometimes with treatment also it's at the peak. Sometimes without treatment it is at the bottom. So the patient is absolutely fine. It is an autoimmune disease characterized by acute flares, commonly presenting with rash, joint pain, and fever. So these are the most important things. Joint pains, this is how patient will come. They will tell you, yes, I also have fever. Rash is something that you will diagnose. Characterized by antibodies against anti-dsDNA. Multiple organ systems are involved: joints, kidneys, brain, skin, heart, and bone marrow. More common in females, 10:1. Risk factors, family history, use of oral contraceptives. Till date, we have not found why oral contraceptive use leads to SLE, but it only emphasizes that female hormones, they predispose to this 10:1 ratio. Hormone replacement therapy also does the same. And the presence of other autoimmune disorders leads to SLE. Pathogenesis, viral fevers. So viruses, they attack the cells, bring out the nuclear antigens out into the circulation, and people who are genetically predisposed, they will develop SLE. And antibodies, they will form these antigen antibody complexes, and they will deposit in multiple organs, kidney, skin, brain, and eventually leading to amyloidosis like situation and damage of those particular organs. Hence, it is a form of type 3 hypersensitivity. There is polyclonal activation of the B cells producing multiple types of antibodies against DNA. And whenever the antigen is being attacked by an antibody, the fixation is done with the help of complements. So this leads to formation of this antigen antibody complex, but complements get depleted. So which complements we usually measure? It is C3 and C4. They are depleted. Hello. Sir,
C3, C4 will be low.
25 are TDS.
Sir.
Yes, C3, C4 will be consumed and they will be low. In fact, C3, C4, they are used to assess the activity of the disease. Lower they are, active is the disease. Okay? Yes? Okay. The variants are drug-induced lupus, we were just discussing. So anti-histone antibodies. Remember, histone antibodies are present in drug-induced. Drug-induced drugs are hydralazine, isoniazid, procainamide, HIP. His is histone. So, hydralazine, isoniazid, and procainamide, they are famous to cause anti-histone antibodies. Although neomercazole, that is methimazole, is another drug which is known to cause anti-histone antibodies. EPLA, Hughes syndrome, it is associated with SLE. Now, many people say if the patient has SLE, they will have EPLA. No, EPLA is a separate condition which is associated with SLE. In EPLA, there is increased risk of arterial and venous thrombosis, increased risk of atherosclerosis, increased risk of fetal loss and obstetric complications. Lupus nephritis, a very strong variant of SLE, anti-DNA immune complexes are deposited in glomeruli, leading to both nephritic or nephrotic. In nephritic, blood cells will be present in urine plus proteins. In nephrotic, it will be the proteins only. Diffuse proliferative is the most common and most severe type, usually requiring renal transplants. Liebman-Sachs endocarditis, a cardiac variant of SLE, non-infectious endocarditis associated with formation of thrombi and vegetations on mitral and aortic valves. Liebman-Sachs endocarditis, and of course, Raynaud phenomena. What is Raynaud phenomena? What is Raynaud's phenomena?
Exposure to
Infection and exposure to cold.
Yeah, what happens?
Peripheral vasoconstriction.
So pale, blue, red. So color changes occur, but they are reversible. Raynaud's phenomena is reversible because it is secondary to autoimmune diseases. But there is a condition known as Raynaud's disease. What is it? Raynaud disease is where actual thrombotic, yes, thrombotic occlusion of digital vessels occur, leading to gangrene. Now, Raynaud's phenomena will never cause gangrene, but Raynaud's disease will cause gangrene. Is that clear? Yes or no?
Yes, sir.
Great.
Yes, sir.
So symptoms are fatigue, fever, weight loss, arthralgia, serositis. So some people can have purely pericardial effusion, pleural effusion, and myocarditis. Neurological, many of these patients have psychiatric changes. Stroke, seizures, headaches, even CVT. CVT is
Critical vein thrombosis. Cerebral venous thrombosis.
okay, cerebral venous sinus thrombosis. In renal, of course, hematuria and proteinuria. Hematuria, nephritic syndrome, proteinuria, nephritic and nephrotic both. Immunology, very important. So many antibodies. Main is ANA should be positive. The criteria to diagnose SLE begins with anyone? The criteria to diagnose SLE begins with a positive ANA. Always remember, I see people being labeled as SLE right and left without a positive ANA. Why, if ANA is positive, only then you start thinking, is it SLE? Is it not SLE? So a positive ANA's algorithm is SLE, no SLE. So that means it all begins with a positive ANA. So it has to be positive. But the problem is, it is very, very sensitive and low specific. So it can come positive in viral diseases, chikungunya. Very, very often in chikungunya, ANA comes positive. Cancers, ANA will come positive. So these are very sensitive tests which have low specificity. So we want to go very clear. Okay, ANA is positive. Next, what? Fine, I will break it down. I will do an ENA. I will do extractable nuclear antigen test. What I expect to find? I expect to find an anti-dsDNA test. Okay.
Sir,
yes.
sir, one doubt. For ANA, we have to do ELISA or immunofluorescence.
See, you can do any of them. You can do ELISA, you can do immunofluorescence. IFA is much more sensitive because you can get a photo with antibodies. They look green in color, and you can see speckled pattern or homogeneous pattern, clumping. So IFA is any day better because you do it immunofluorescence. ELISA is antibody test, just like antibodies can come positive in HIV also. So you will need to do IFA then. Is that clear? Hello?
Yes, sir. Yes, sir.
So if you are asking me the type of choice, IFA is the type of choice any day. Immunofluorescence, okay? So anti-dsDNA, so ANA is positive, I break it down, I try to find what? Number one, anti-dsDNA. If it is positive, we understand that it rises during flares, it has high specificity and low sensitivity, it has a poor prognostic factor, often indicates that renal disease might be present. Then comes anti-Smith antibody. Very, very specific. If somebody has anti-Smith antibody positive, ANA titer 1:80, it is SLE. 1:80 is a very slow, low titer. Whenever it is more than 1:160, that is when we start thinking, okay, SLE ho sakta hai. But if it is less, but anti-Smith is positive, then we leave everything else and we start treating the patient for SLE. Anti-histone antibody, not that it cannot be present in SLE, but it has high chances to be present in drug-induced lupus. ANCA will never be positive, like DIP will never be seen in case of rheumatoid arthritis. ANCA will never be positive in SLE. This is a benchmark. ANCA will never be positive. C3, C4 will be decreased during the acute flares. ESR, CRP will be elevated. Pancytopenia will be there, leukopenia, thrombocytopenia, defining criteria of SLE, elevated PTT because of lupus anticoagulant, increases the risk of thrombi and miscarriages associated with EPLA. Urinalysis will tell you about proteinuria and hematuria. Okay. So, diagnostic criteria, SLE is diagnosed if 4 or more of them can be present. It is easy to remember Rashnia 4, that is why it is written like that. But remember, ANA positivity is where it all begins. So this is the first step. Renal disease, arthralgia, classically non-erosive arthritis. Erosive arthritis is seen in rheumatoid arthritis, psoriatic arthritis. Psoriatic is so much so that it is known as arthritis mutilans, mutilates. Okay, R for renal disease, A for arthralgia, S for serositis, pericarditis, pleuritis, ascites. Hematological abnormality, leukopenia, thrombocytopenia, anemia, neurological abnormalities, seizure, headaches, altered sensorium, immunological derangements, that is, these positivity of all the antibodies, specifically ANA. 4 types of rash, malar, discoid, photosensitive, and stomatitis, aphthous ulcers. Aphthous ulcers can be a manifestation of SLE, very common. Gets treated with steroids so fine. Okay. So many times the questions are asked about acute flares, and because we are only reading superficially, we miss out few things. Whenever somebody is asking about the acute flare, the treatment is number 1 steroids, that is methylprednisolone, given as 3-day pulse therapy plus hydroxychloroquine. Methotrexate is not there. Remember, methotrexate starts showing its effect after 6 weeks. So whenever there is a acute onset, acute flare, treat them with HCQS and steroids. Remember this. This is the first line of understanding of SLE management. And yes, management is often dictated by specific organ involvement. If the patient has suffered a renal injury, then may require dialysis. So on and so forth. Arthralgia, NSAIDs, and antimalarials. Dermatological findings and joint pains, often used in combination with steroids. Remember the acute flare, steroids and antimalarials. Immunosuppressants like azathioprine, methotrexate, mycophenolate. Patient non-responsive to steroids, patient unable to tolerate steroid taper, and lupus nephritis, specifically cyclophosphamide is used, plus MMF, that is mycophenolate. But remember, if the patient is pregnant, drug of choice is azathioprine. Is that clear? Biological, it is belimumab, inhibits B cells just like rituximab does, given in patients who do not respond to steroids and other immunosuppressants. There are certain pearls for the MRCP exam. cardiovascular disease is the leading cause of death in patients with SLE. This question is asked many times. That the so-and-so patient has gone to you diagnose as SLE, so on and so forth. And what is the most common cause of death? It is cardiovascular. Anti-Smith, most specific for SLE. Anti-histone, usually positive in drug-induced lupus. Anti-dsDNA should be negative in drug-induced lupus. Just like the question that one of you asked, that why in this infliximab, adalimumab, even if anti-dsDNA is present, why do we call it drug-induced lupus? Because it is a reversible lupus. C3, C4 decrease in SLE flare, congenital low C4A. So C4A and C4B can be a predisposing factor for SLE. This is congenital inheritance SLE. SLE often becomes worse during pregnancy and puerperium. The only cornerstone is azathioprine. Congenital heart block, neonatal complication of maternal SLE. Why? Because of SSA antibodies. This is also asked in the exam. Is that clear? So let's see if I have questions on them. One of you were asking. Let's see. I think I have. All right. I will need contributions from you all. A 28-year-old woman presents with fatigue, joint pain and a rash over her cheeks, nose that worsens with sun exposure. She also reports intermittent swelling of her hands. On examination, she has tender, swollen joints in her hands and a malar rash. Lab findings show a positive ANA and elevated anti-dsDNA. What is the most likely diagnosis? So, it is a very easy question. Answer is SLE. So, patient has classical features of SLE, malar rash, arthritis, positive ANA, anti-dsDNA. Arthritis can cause symmetrical polyarthritis without rash or without ANA. Okay. Question number 2. A 35-year-old patient, young woman with SLE, so she is diagnosed as SLE, presents with new onset lower extremity edema and hypertension. Urinalysis shows 4+ proteinuria and microscopic hematuria. So what is the diagnosis?
SLE with nephritic syndrome.
Yes. So it is nephritic syndrome. Secondary to
diffuse paralysis.
Lupus nephritis. This is the complete diagnosis. So whenever we say the outcome, we should also try to associate it with underlying condition. Okay. So you are correct that the nephritic syndrome has happened. Serum creat is elevated at 2. What is the most appropriate next step in her management?
Perform a renal biopsy.
Anybody else?
Renal biopsy is an ideal choice.
Yes. So she has new onset nephritic syndrome and we are trying to label it to lupus nephritis. The only way to label it that she has lupus nephritis is to perform a renal biopsy.
So it's diffuse proliferative nephritis.
Yeah, that is the usual and the most severe type of nephritis that we see in the cases of SLE. Okay. Practice question number 3. A patient with a history of SLE comes with confusion and seizures. Her MRI of brain shows T2 signal increased in white matter without evidence of infarction. Her serum sodium is only 115. What is the most appropriate initial treatment? This is called a red herring question. So when I tell you that rheumatology can come in various shapes and sizes. This is how it comes. What is the answer? So,
hypertonic cell.
yes. So this is altered mental status with hyponatremia. The reason may be any, but if the altered mental status is due to hyponatremia, then the answer will be hypertonic saline. Immediate. Hello. कितनी आई शुगर? पर ठीक है, तो सी मैंने 14 यूनिट लगा. So thanks. That's it. This is for SL. I hope you are enjoying the way we are doing.
Yes, sir.
Yes, sir.
Yes, sir.
But it is not finished. So many topics are left.
Yeah, there are several topics. We are just continuing to enjoy this. Okay. Rheumatology is a long train with a lot of bogies in it. All right. So systemic sclerosis. Systemic sclerosis. System is whole body. Systemic sclerosis means pathar ho jana, stonification, fibrosis, hardening, or it is also known as scleroderma. Old name, not very used these days, but systemic sclerosis. So all the organs tend to become fibrosed and leather-like. So it is a connective tissue disorder characterized by progressive thickening and induration of the skin and or other structures like subcutaneous tissues, muscles, and internal organs. The triad of systemic sclerosis is number 1, autoimmunity, non-inflammatory vasculopathy seen as telangiectasias, and collagen deposition within the fibrosis. So there is vasculopathy. It is not vasculitis, it is vasculopathy. There is no inflammation. Variants are, there is something known as localized scleroderma. These terms are not, very often used, but then for the sake of involvement of the body, it is used. Affecting only the skin and muscles, no internal organs involved. Many times in the question paper, lung involvement is mentioned. You just need one organ involvement to cause it diffuse systemic sclerosis. Okay? So morphia is a type of scleroderma which is localized, where there is Kupti-Sabar pattern of linear thickening of skin. It is like skin gets thickened like this. Then comes the diffuse systemic sclerosis, in which, of course, there are other variants. Many times people confuse the limited scleroderma with localized. You should not do that. Remember that in localized scleroderma, no internal organs are involved. Crest syndrome is very important. It actually symbolizes systemic sclerosis. C for calcinosis. There is deposition of calcium in the body, in the skin. Calcinosis is not a single word. It is calcinosis cutis. Cutis is skin. Calcium deposition in the skin. Imagine somebody, you can palpate the calcium under their skin. It is calcinosis cutis. Raynaud's phenomenon. Esophageal dysmotility, usually presenting with GERD-like symptoms. Sclerodactyly, sausage fingers. Patient says, I cannot bend my fingers. Sclerodactyly. Telangiectasias on the cheeks. Classically, on the cheeks, the patient has telangiectasia here. Classically, anti-centromere antibodies are positive. Very important question. Crest has anti-centromere antibodies. Classically, lungs are involved, leading to pulmonary hypertension. Raynaud's phenomena may be the only or the first sign. Gut sclerosis may lead to bacterial overgrowth and malabsorption. Diffuse systemic sclerosis, anti-CL70 anti-topoisomerase antibody positive. If it is anti-centromere, C for centromere, C for crest. Anti-topoisomerase, it is present in the diffuse systemic sclerosis. Patients usually have kidney involvement. there is, because of kidney involvement, there is hypertension and there is renal crisis responding to ACE inhibitors, ARBs, and lung fibrosis. So this is the diffuse systemic sclerosis. The pathogenesis is, we understand there is extensive deposition of collagen in skin and in the internal organs. There is proliferation of the microvasculature to provide blood flow to all this new collagen being deposited, but this is not inflammatory. So there is no vasculitis. So many times in the true and false questions, they try to encroach on these two terms, vasculitis and vasculopathy. Beware of these statements. Patient of scleroderma does not have vasculitis, it is vasculopathy. Chronic inflammation is there, increased release of inflammatory cells, which continue to process the fibrotic injury. There is esophageal dysmotility because of atrophy of the smooth muscles in the tubing, that is the esophagus and the intestines, decreases the lower esophageal sphincter pressure, leading to reflux and Barrett's esophagus and adenocarcinoma of the esophagus. Prognosis depends on lung involvement, depends on kidney involvement, depends on cardiac system involvement. It has one of the highest mortalities among the systemic autoimmune process. Limited scleroderma, that is morphia, is a benign condition. Very important, somebody presents to you with joint pains and diffuse itching. Don't subjugate them telling, okay, take Allegra. No. Try to investigate if this patient has, because there are so many inflammatory cells in the skin leading to itching. Unless you act smart and act fast, you may miss the diagnosis. Acid reflux, progressive dyspnea, dry cough because of ILD, myalgias, arthralgias, palpitations, irregular heartbeat. Scleroderma may lead to sclerosis of the conduction system of the heart, leading to complete heart blocks. Evaluation, ANA will be positive. In the ENA, you will see anti-scleroderma, anti-SCL70 or DNA topoisomerase positive in systemic sclerosis. Anti-centromere antibody with CREST syndrome. ANA will be positive, speckled or centromeric pattern. Centromeric pattern is usually CREST syndrome. Nuclear pattern is usually for systemic sclerosis. Serum creatinine is important to find out if kidney is involved. CXCL4 is the this cytokine which is indicative of pulmonary fibrosis. Anti-pro-BNP may rise. Anti-pro-BNP rises due to pulmonary hypertension. ECG to assess cardiac involvement, PFT for restrictive lung defect. Treatment, methotrexate, MMF, cyclophosphamide, wonderful drug, very effective, but use them when methotrexate or MMF fails. Why? Because cyclophosphamide has its own problems and side effect profile. ACE inhibitors are specifically given during renal crisis of scleroderma. Antihistamines for pruritus, calcium channel blockers to prevent Raynaud's phenomena like amlodipine effect, and bosentan and ambrisentan to be given with tadalafil to treat pulmonary hypertension. So these are the major 5 treatments. One is methotrexate and MMF and cyclophosphamide, and then ACE inhibitor and antihistamines. The patient should be on all of them to be, if the patient is of this scleroderma. Okay, let's find out if I have questions on them. So this is just the revision of scleroderma. I haven't erased something on the screen. What is it? What is this? Anyone?
Can you give a clue, sir? What is it?
Telangiectasia.
Wonderful. Yes, that's it. This is telangiectasia. Wonderful. Very well. Very well picked. So, in systemic sclerosis, a 45-year-old woman presents with progressive shortness of breath, fatigue, thickening of skin on her hands and face. So she has shortness of breath, she's tired, she has thickening of hand and face skin. She also reports severe heartburn and difficulty in swallowing. Dysmotility plus GRD. On physical examination, there is thickening and tightening of skin on her fingers known as sclerodactyly and small dilated blood vessels on her face and hands. Lung auscultation reveals bibasilar crackles. Lab test is positive for ANA and anti-topoisomerase antibody is positive. PFT shows a restrictive pattern. Which is the diagnosis? What is the diagnosis? The answer is systemic sclerosis. Now let me change it a bit. Lab test reveals positive ANA and anti-centromere antibodies. What is the answer now?
CRUSH syndrome.
Okay, good. Because she has all the components of CREST syndrome also.
And restricted pattern is seen, sir. So then it goes in for a diffuse or acute with a lung
You are right.
involvement.
No. Diffuse has two types, CREST and systemic sclerosis. Pulmonary hypertension can be present in both.
It's not pulmonary hypertension, sir. It's a bibasilar CREST with a restricted
This is
pattern.
what I'm saying. That if the anti-centromere antibody comes positive, then you will not cause it diffuse SLE, diffuse systemic sclerosis. Because this, I'm emphasizing on the fact that just by changing the antibody, you can present it differently. We cannot challenge this, that there is presence of lung involvement. That is why it cannot be CREST syndrome. Am I clear?
Yes, sir. But okay.
So the overlap syndrome, that is why diffuse is divided into two. Otherwise, they could have called it systemic sclerosis only. But presence of the particular antibody is changing the diagnosis. That's all.
Sir, so one more time, the diffuse is divided into limited and
systemic.
And systemic, sir.
Yeah.
But in limited anti-centromere variety, we'll get only pulmonary hypertension, but we don't get this restrictive pattern.
You are absolutely correct. But what I am emphasizing is that just by changing the antibody, so let us say in anti-centromere antibody is positive in the question paper, and you have both the answers, systemic sclerosis and CREST syndrome. What will you mark?
I go for systemic sclerosis, sir, or is it wrong? I'm not sure. I go for systemic sclerosis.
Yeah. So I am telling you that you will mark CREST syndrome. Why? Because definitely before these antibodies were invented, they were all known as scleroderma.
I have a doubt. In scleroderma, will anti-70 antibodies will be positive or negative?
Which antibody?
No, sir. In CREST syndrome,
yeah,
anti-SCL70 will be positive or negative?
In CREST syndrome, anti-SCL antibody should not be positive. I'm not saying it will not come positive. Okay. In the real life scenarios, anything is possible. But for examination purpose, the teacher, the examiner is trying to get an answer from you that you can correlate the two things or not.
Okay, sir. I understand, sir. No,
so
only for discussion sake.
For discussion, I am telling you, even in the absence of both the antibodies, you can make a diagnosis of scleroderma.
Okay, fine. Yeah.
If everything else is positive, if the patient has dysmotility, calcinosis, the patient has Raynaud's phenomena, the fingers are, I think I have photos with me where patient does not have anything else. And the patient, we have done a angiography, peripheral angiography, and there is no digital thrombosis anywhere. But the patient has all the features of scleroderma, but then ANA is negative. Okay, so nowadays they say anti-synthetase syndrome it is. So fine, I can understand. But then it is just based on antibodies, they change the name of the disease.
Okay.
Okay,
sir. Because this question comes in every, I think.
Yeah, definitely.
Master's papers, I think it comes.
Definitely is there. The only point I'm is that if the antibody changes, change the diagnosis. Okay. Yeah. So, systemic sclerosis, skin involvement, vascular abnormalities, GI, pulmonary, interstitial lung disease, pulmonary artery hypertension, renal risk of scleroderma crisis. Autoantibodies, only two are important. One is anti-topoisomerase associated with diffuse cutaneous systemic sclerosis and higher risk of interstitial lung disease. Anti-centromere antibody, more common in limited, associated with CREST syndrome. So once you have anti-centromere antibody and anti-topoisomerase, you can shift to the type of the disease.
So this one I was asking, sir. Sir,
exactly.
Go back to the previous slide, sir.
Yeah, this is what I'm saying. Exactly.
This anti-centromere antibody positive.
Yeah.
Features of ILD. What will you use?
If anti-centromere antibody is positive
with the ILD like features.
Yeah, we will. Yeah, I'll tell you. We will write it SSC CREST.
SSC CREST. Okay.
Okay. Otherwise, if the patient has anti-topoisomerase positive, we stop here.
Yeah. Because that was a question you asked here before, sir. Before question was this, I suppose. Because anti-centromere antibody positive with a restrictive lung pattern fits in with SSC CREST. Yes.
So, yeah, agreed. So, just the presence of antibody will make me, a diagnosis of CREST.
Okay. Sir. Okay, sir.
Both of them are SSC.
Okay, sir. Okay.
Both of them are SSC. It is just a variant. We just try to name it.
Yes, sir. Because in past test, the similar question was asked.
Yeah.
They asked for what type of antibody you will look for. They have given both choices: anti-topoisomerase and anti-centromere.
So whenever the reverse question comes that the higher incidence of interstitial lung disease is seen in which antibody, then the answer will be SCL70.
Yeah. Okay. Fine.
If the reverse answer is asked.
Okay, sir.
Yeah. So if they ask if the calcinosis is present or sclerodactyly, telangiectasias, they are all present. So which antibody will you be looking for? The answer will definitely be anti-centromere. Of course, ऐसा नहीं है कि SCL70 will not come positive, but there are higher chances of anti-centromere coming positive.
So do we need to have all the 5 to say it is anti-centromere antibody, or it's just enough if you have 1 or 2 in calcinosis, Raynaud's, insufficient dysmotility?
See, if you are labeling it as if you are labeling it as CREST, then obviously you need all of them. But if you are just labeling it SSC CREST, that means possibility is there that Raynaud's may or may not be there. Usually Raynaud's is missing, everything else is present.
Yes, sir. Yes, sir. So we miss Raynaud's.
So this is, usually Raynaud's is missing, everything else is present. So this is finger thickening, scleroderma presenting with finger thickening, you can see here. This is Raynaud's phenomena, and these are the telangiectasias, okay? Small spider wings. So again, here I mentioned focus on unique antibody profiles and their associated systemic manifestation for differential diagnosis. So that is all for today. Next time we will be covering gout and pseudogout and dermatomyositis, polymyositis. And of course, we will be rushing through APLA and all. So we will have 3 classes, and the first one just concluded. So we will be finishing it in 3 sessions. Any problems, any questions?
No, sir.
So kindly tell us how to differentiate between so I think you are having the slides. How to differentiate between osteoarthritis and rheumatoid. I think this is what they are.
Yeah, that is okay. That is a very, very genuine question, and it has been asked more than a number of times in the exams also. So one is that you have to focus on whether early morning stiffness is present. So early morning stiffness is in rheumatoid arthritis. Let me just make the screen bigger so that I can write. So one is early morning stiffness, EMS. It is characteristic for rheumatoid arthritis. Evening stiffness, it usually goes in the favor of osteoarthritis. So as the day progresses and the patient gets better, it is rheumatoid arthritis. Worse with the day, it is osteoarthritis. Involvement of DIP, osteoarthritis. Involvement of PIP plus MCP. This is rheumatoid arthritis. Involvement of an overused joint, osteoarthritis. Involvement of random joints, rheumatoid arthritis. Presence of constitutional features like fever, fatigue, rash, rheumatoid arthritis. Osteoarthritis will not have anything else.
Duration of symptom also would be there.
Oh, it is, yeah, duration of symptoms again 3 months. Oh, this osteoarthritis is slow to happen. So there will be long pain, long stiffness. Okay. And if
what about the X-ray?
X-ray findings.
Yeah, so in X-rays, what you will see is osteopenia in case of rheumatoid arthritis, and in case of osteoarthritis, you will see thickening of the bone, because usually these are weight-bearing joints. So there will be breakage of the bones in case your osteoarthritis images are there. So in the X-ray, joint space will be narrowed in case of, should I clean it? So in osteoarthritis, you will be finding joint space narrowing. Joint space narrowing will be there. Plus, there will be signs, telltale signs of injury and healing. They are seen as osteophytes. Osteophytes are also known as bony spurs. And there will be cystic degeneration under the subchondral area. Cystic degeneration, subchondral sclerosis. Yes, that is the term that is used. Subchondral sclerosis that happens in osteoarthritis. Whereas in case of rheumatoid arthritis, okay, this joint space narrowing is only for weight-bearing joints. In rheumatoid arthritis, joint space narrowing occurs, definitely occurs, but it occurs in the symmetrical joints. So every joint will have narrowing. So all small joints of hand they will have. Then there will be erosions. You will never see erosions in case of rheumatoid arthritis. Then you will see periarticular osteopenia. Very important. Periarticular osteopenia. Classical for rheumatoid arthritis. And sometimes fusion can occur. Fusion means ankylosis can occur in rheumatoid arthritis. Of course, rheumatoid arthritis comes with other systemic features like eye involvement, lung involvement. In osteoarthritis, nothing of that will be there. So cause of osteoarthritis is wear and tear, aging, whereas rheumatoid arthritis causes inflammation, autoimmunity. As far as early morning stiffness is concerned, for osteoarthritis, it is less than 30 minutes. For rheumatoid arthritis, it is more than 1 hour. Is that clear?
Okay, sir. Thank you. Thank you. Nice.
ESR, CRP, they will be normal in case of osteoarthritis, but they will be elevated in case of rheumatoid arthritis.
Rheumatoid. Okay.
Osteophytes, they are characteristic for osteophytes are also known as bone
spurs.
Bone mice. They are a osteoarthritis. And then, of course, Haberden nodes and those and deformities, botonier deformity, they will be more common in rheumatoid arthritis.
Sir, Haberden nodes is common in the rheumatoid. Haberden nodes and Bochets common in osteoarthritis.
Yeah, they are seen in osteoarthritis. These nodes.
Deformities are more common in rheumatoid.
Say again.
Haberden nodes and Bochets nodes are common in osteoarthritis. Sir.
Yeah.
Yeah.
But then these botonier deformities, they are common
in rheumatoid arthritis.
The deformities are basically because of ankylosis. So the damage happened and then the joint they fused in a wrong shape. Anything else? Any other question?
No, sir. Thank you, sir.
Okay. Thank you. All right, doctors. Thank you very much for your encouraging
sir.
and
Thank you, sir.
very involving session. Thank you very much.